We are looking at a severe cutaneous adverse drug reaction. The skin is frequently the first organ to physically manifest a systemic pharmacological crisis. While almost any medication can cause a rash, drugs acting on the autonomic nervous system, as well as structurally similar anti-epileptic agents, are exceptionally frequent triggers for these violent dermal responses. Clinicians often shorthand these reactions as allergies, but true IgE-mediated allergies only account for a fraction of these eruptions. Treating all drug-induced rashes as a single, uniform pathology leads to misdiagnoses and incorrect treatment timelines. This diagram illustrates the three distinct cellular pathways driving ANS drug eruptions: interference with local histamine regulation, drug-induced photosensitivity, and structural immunogenicity triggering a delayed T-cell response. To properly manage a cutaneous drug reaction, we have to look at the physical presentation on the patient's skin and reverse engineer its origins down to the exact microscopic cellular trigger. Accurately identifying which of these cellular mechanisms is actively damaging the tissue dictates the timeline of the reaction, the potential for systemic severity, and the specific clinical intervention required. We begin with the most immediate presentation, urticaria or hives. On the left, the characteristic raised wheals. On the right, the physical structure of the responsible ANS drug compound. Standard allergic hives require prior immune sensitization and the presence of IgE antibodies. Many autonomic nervous system medications bypass this requirement entirely. They are capable of directly stimulating mast cells upon the very first exposure. Looking at the dermal layer, the ANS drug molecule physically docks with receptors on a mast cell. This triggers an intracellular cascade. The mast cell rapidly degranulates, ejecting histamine vesicles. These molecules cause adjacent capillaries to vasodilate, leaking fluid upward to form a raised wheal. When rapid onset hives appear shortly after administering an ANS drug, it points directly to this localized, chemically induced histamine cascade, ruling out a slower, structurally driven immune response. The second mechanism relies on an external catalyst. Several classes of ANS-related medications, particularly certain antipsychotics, antihypertensives, and NSAIDs, are highly prone to inducing photosensitivity. The defining clinical feature is severe sunburn-like erythema or blistering that is strictly confined to areas of the skin exposed to sunlight. For this reaction, drug metabolites circulating in superficial capillaries absorb penetrating ultraviolet radiation. This energy instantly transforms the drug into a highly reactive chemical intermediate. These toxic intermediates attack adjacent epidermal cells, rupturing membranes to clinically present as a fluid-filled blister. This is an environmentally catalyzed chemical burn happening from the inside out. The body's immune system is completely bypassed during this initial gamage phase. The presence of sharp spatial boundaries on the patient's rash, clearly separating UV-exposed skin from shaded skin, clinically confirms that a circulating systemic drug is reacting violently with the local external environment. The third mechanism involves structurally complex, aromatic ANS-related agents, such as specific antipsychotics and the anticonvulsant phenytoin. These drugs possess a high potential for producing reactive metabolites during processing. In this animated diagram, we see the core immunological trigger. These complex drug molecules act as haptens. They physically lock on to much larger native skin proteins, merging to form a single entity known as a hapten carrier complex. The skin is highly susceptible to this specific process because the dermis is densely populated with active immune sentinels, primarily memory T cells and dendritic cells. A patrolling dendritic cell identifies this hybrid hapten carrier complex as a foreign invader, engulfing it and migrating deeper. It then presents the antigen to a memory T cell, transferring a signal that prompts the T cell to rapidly clone itself into thousands of active immune cells. This timeline graphic illustrates why these reactions are delayed. T cell proliferation is a biological process that takes time. The resulting tissue inflammation typically manifests as a maculopapular eruption 1 to 2 weeks after the patient starts the medication. A spreading maculopapular rash appearing weeks into pharmacotherapy indicates a deeply entrenched systemic cellular immune cascade,
requiring an immediate reassessment of the patient's medication regimen.
This cell-mediated pathway can present in morphologically distinct ways depending on the specific pharmacological trigger. Widely used ANS modulators, primarily beta blockers, are known to induce specific lichen planus-like or lichenoid eruptions. But the highest risk scenarios arise from medications that combine extreme structural immunogenicity with a low therapeutic index, particularly the structurally related anticonvulsants. The severe clinical consequence of this extreme immunogenicity is drug-induced hypersensitivity syndrome, commonly known as DRESS. As shown in this anatomical model, the pathophysiology of DRESS occurs when the massive T-cell response escapes the localized environment of the skin. The activated immune cells travel via the vascular system to aggressively infiltrate internal organs, most notably the liver and lymph nodes. At this stage, the cutaneous eruption is accompanied by severe systemic markers, including a high fever, facial edema, and dangerously elevated liver enzymes. Recognizing the high risk of DRESS in specific ANS pharmacotherapy transforms a dermatological observation into a critical, life-saving systemic assessment. Diagnosing cutaneous adverse reactions requires correlating the physical presentation and the clinical timeline directly to the underlying cellular mechanism. Looking at our diagnostic matrix, the first pathway is characterized by a rapid onset and direct mast cell degranulation, resulting in urticaria. The second pathway requires UV exposure, interacting with circulating reactive intermediates, resulting in localized blistering or erythema. The third pathway operates on a 1 to 2 week delay, driven by hapten protein binding and subsequent T-cell activation to produce a maculopapular rash. And the fourth pathway escalates that T-cell response to internal organ involvement, driven by immunogenic drugs to cause the severe systemic syndrome, DRESS. As a highly active immune organ, the skin identifies and processes structural drug complexity, making it uniquely vulnerable to these autonomic nervous system agents. By deconstructing these eruptions from the visual macule down to the instigating molecule, clinicians can look past the surface of the skin to accurately diagnose and halt destructive pharmacological cascades before they escalate.